Good afternoon. Thank you, Francois, for making this seminar possible, and to William, who is a PhD student at Oxford and comes from Brazil. He's a collaborator of mine since he was 16. He found the course that I was giving at the University of Minas Gerais, which is there, Belo Horizonte, and then he applied to do as someone in vacation, and he came in. It happened that he was the best student among all, and since then he is published with us a lot, but now it's 10 years later now, right? Malaria is, as most of you would probably know, is a very old disease, but the problems remain unsolved because still we have 220 million people that suffer from malaria and 660 deaths. And most are children, and usually they die in areas of poverty because they don't have access to drugs. And the second problem is we don't have an ideal drug. Even if you are in England and you go to travel to Africa, you cannot take a pill to protect you against malaria. So all the antimalarials that we say that is prophylactic, they are not really prophylactic. They are attacking the blood stages when the disease starts. The ideal drug should aim all those stages. Malaria has a very complex life cycle, and it starts when a mosquito bites you. So one of the measures to avoid malaria is using repellents or the bed nets impregnated with insecticides. But the drugs, they are usually, all of them or most of them are schizonicides, which means that they kill the schizons in the blood. And in some cases, they have to kill the very late stages, which remain in the liver for months or years, the case of P.vivax. So one of the approaches that we are doing here is trying to find drugs that will attack all those stages. And interrupting the mosquito cycle would also be very important because then you can avoid people getting the disease. In the map, we see all the color symbols means that the resistance against the drugs exists, even against the artemisinin, which is the newest drug. And the quinoline molecules are the basis of most of the antimalarials, and they were initially extracted from a plant, which was from, I'm going to show you later, but now it's all synthesized, synthetic drugs. And the parasites are resistant to all of them, to chloroquine, to amodiaquine, and even to mefloquine. All the molecules that you see there are newer molecules, and some of them act against the blood stages and against the liver stages as well. Very recently, Professor White published this review showing that, unfortunately, even in Africa, we now have resistance to the artemisinin drug. But this problem is even more serious in the Southeast Asia, where parasites are resistant to artemisinin, which is considered the newest and most active drug. It acts very fast. In a few hours, it kills the parasite. But we will no longer do it because now the parasites became resistant. In Brazil, the situation is much different because most of the country has only Vivax, which doesn't kill you. It's mild. In the past, it was called the benign malaria, whereas falciparum, which is the parasite that's most common and that kills you, is falciparum malaria. In the curve down there, you see the total number of cases that were increasing as the Amazon became colonized by the Brazilians looking for work, and then malaria became a big problem. Before it was controlled thanks to chloroquine and insecticides, but then it became a big problem. And now most of the cases are, as you see there, by Vivax. And the figure there is the way that you diagnose the parasite in the blood. It's a blood parasite, and it's not very easy to suspect that the person has the disease. And many people die in Brazil or in England or in Canada because the medical doctors receive a patient that has fever and he does not suspect. Usually they think of HIV, Ebola, dengue, and so on. And if a doctor does not think of malaria, someone will not find it in the blood smear because they will just simply not take the blood smear, which should be taken at the peak of parasitemia. So in Brazil, in my laboratory, since I was doing my PhD student, I was training students, doing masters, and working with malaria. So we have published all those papers. Most of them, in this case here, deal with plants. We have three approaches to find for new drugs. One of them is testing antimalarials. As you see, when you use the empirical approach, and that used to be very common in Brazil, the chemists, they just take any plant, fractionate, and they find new molecules. They can publish papers, but if you test them against malaria, only 1% is active. And then we changed our approach using drugs that are used by people to treat fever, which was a more recent approach. And as you see, among 50 plants that were claimed to be useful to treat fever, we found 50% of them active. The first model, which is very simple, that we used to test was malaria in the mice. Now it's a little bit difficult to do this because of the people that protect the animals, and that creates a big problem to us because we cannot test in people and we cannot test in monkeys. So we have used mice, and we still do, but now we only test in mice the very active drugs that we find in vitro. And we were able to develop many years ago even a resistant strain in mice by giving them increasing doses of chloroquine. So now we do have a parasite that is chloroquine resistant, but unfortunately it's not stable. But it's a very good model. So we can test drugs in mice that have malaria, chloroquine sensitive or chloroquine resistant. And this is published in a Brazilian paper. That was my first paper, as a matter of fact, when I was a student. And it still is the only one where people have developed the chloroquine resistant strain. It's unstable, so we have to keep pressure with the drug. It's exactly like in people. If you remove chloroquine from an area, the parasites again become chloroquine sensitive, and this is a very important thing for malaria control. So we were able, only after 76, when I mean we, the scientists, were able to cultivate falciparum, which is the deadly parasite, and we have this culture in Brazil, in our laboratory, and this person who is Traeger and Jensen, they published in Science showing that you could grow the parasite if you decrease the concentration of oxygen. And you do it simply by lighting a candle. So it's called the candle jar test. Now you can buy the mixture of oxygen and CO2 in the right concentrations and keep this. But it's still a very fine and inexpensive way to keep parasites. But you have to ask the students if they are not very happy to come every Saturday and Sunday. Even in the carnival, they have to come to the lab. And of course, it's not easy, but they have to do it. And then you grow the parasite and you test. We have many tests that we have now established and work very well. The first one also was described in 1979, consists in growing the parasite and then offering it tritiated, labeled, radioactive label hypoxanthine. And this method is very precise, although we use radioactive molecules. This is a beta wave, so it's not dangerous. You can throw in the sink, but it's still, you have to keep the plastic for 70 years before you can discharge it. And then we changed it for other methods that you see in this left corner, which is a monoclonal antibody test in which the parasites grow, and then you can measure the amount of growth by using monoclonal antibodies against the histidine-rich protein, which is the HRP2. Or we can use a cybergreen, that is a DNA intercalant that is fluorescent, or the fluorescent parasites genetically prepared, and by the old microscopy. That is ultimately the more direct and simple way to see if a drug is really killing the parasite. In Brazil, we have, based on the fact that we had all those technology well established in the lab, and we have many chemists, so every point in Brazil, Brazil is there. You see, I'm sure that all of you watched the World Cup. Oh, what a shame. And so you know where Brazil is. And the chemists are mostly outside the endemic area. The endemic area is in the Amazon, as probably you all know. And so we put together those chemists, and they collect plants, or they synthesize drugs, or they use, like they do molecular modeling. In our lab, which is in the center, is leading those groups to look for antimalarials. And as I said, the first project that we had was ethnopharmacology project, in which we try still now to explore the Brazilian biodiversity and transform the knowledge, the traditional knowledge, in a product. It has been impossible to produce those isolated molecules in a quantity sufficient to work in vivo. So most of the results that I will show you are dealing with the in vitro tests. It doesn't mean that they are going to work against the disease. And I'm going to talk a little bit about some of those plants, especially the very big tall tree from the Amazon, and the other plant which is used to prevent malaria. So they have different aims, and they have different uses. I already mentioned to you, this is the molecule quinine that was isolated from a plant, and the artemisinin that was also isolated from the plant. One of them is the a Peruvian plant that was brought to Japan, and until the Second World War, all the world used quinine from the plants to treat malaria. But then the Japanese closed the islands, and we had no longer access to the treatment. And then two big groups patented chloroquine and developed the synthetic drugs, which were the Americans and the German groups. In Brazil, we have many biomas, as I'm sure you know. The most known one is the rainforest, but the most important for us is the cerrado. I have no translation for this, but I'm showing you several tree species there that are from cerrado. The yellow one, which is called Ipê, a tabebuia plant, is a source of lapachol. Lapachol is the basis of some new antimalarials like tafenoquine, and I'm going to show you this. So exploring this, the steps are just the regular steps. I'm not going to go into it. The chemist takes the plant, grinds the plant, dries it, and then fractionates with several solvents, and then they send to us, coded, all those things, and you see in white the activity in mice. This was years ago when we had free use. And then in this case here, we were able to find a molecule, which is the tormentic acid, that is shown here as a very active molecule. This is the curve is based on the hypoxanthine test, and we use serial dilutions in which we can now find the drug that has an activity that kills 50% of the parasite, and we are comparing with chloroquine. As you see, chloroquine is active in a nanogram concentration, whereas the tormentic acid is still in microgram. So far we found nothing that is as good as chloroquine. This is the plant, Cecropia. It grows everywhere in Latin America, and it's a very medicinal plant used against fever, and it has an activity which is antioxidant activity, but it also has the antimalarial activity. And this is the Amazonian plant. This group of plants, which is the Apocynaceae, they are known because of the amount of alkaloids. They had hundreds of alkaloids inside, and people use the bark. We have studied the bark and the leaves and the wood and all parts of this species, which is published recently. And also we have worked with other species, and other groups in Brazil have published that all the species that they look for, they have alkaloids, and there are many new alkaloids described. In this species, we so far don't know exactly the molecule, but we are giving up on finding the molecule, because as we fractionate, we see that we lose activity. So we probably would go the other way around. We would have to develop a phytotherapy, because probably you need a mixture of alkaloids for the plant to be active. And that's why we have the crude extract being very active. This is very detailed in this journal. It's in English and it's free access, so you can read the paper. The other two species are also active, not as active as Nitidum. And here I'm showing you that not every species has been tested in vivo because of the difficulties to have a sufficient amount to do so. And anyway, there is a clear relationship in most of the cases between in vitro results and the in vivo result, which is in the right corner of the table, the reduction of parasitemia in the mice. In the mice, we only have the microscope to see if they were treated, if they reduce parasitemia, if they are cured. We follow survival, and when you have 40%, 50% is a very good, intense reduction. None of the plants so far was as good as artemisinin. None of them cured the mice, but they have reduced a lot the mortality. This we recently published in Malaria Journal, which is also a free access paper, and it's Aspidosperma olivaceum. Differently from the Nitidum, which was the previous plant, this grows in the south, so it's a totally different biome, but it's in the Cerrado. And it has, the chemists have isolated several molecules, and in this case, you see that we tested 4 isolated molecules, and the best one in the right-hand corner table is number 1 molecule, and the structure is there, which is called aspidoscarpine, after the gender, which is Aspidosperma. And so this molecule is very active. But the chemist tells me, I'm sorry, I cannot give you 1 gram. So if I cannot have 1 gram, I can do nothing about making an antimalarial. Okay? Until the chemists will synthesize it for us. So please, chemists, help us. And the other thing which is interesting about molecule number 1, compound 1, is that you find it in the bark and in the leaves. And that makes life easier because you can have the leaves, you don't have to really spoil the plant. We are trying to convince people to cultivate those species because they grow quite easily. But this is another project that I'm not a botanist, so I cannot do it. I think this is the most important plant that we ever found, and we wasted about 20 years testing it and finding out that it has no activity whatsoever against the blood stages. So one of my students, I quoted them before, it was published in Journal of Ethnopharmacology in 1992. We published showing that people use, the Indians and people that live in the endemic areas, they use this plant, which is called Indian beer. I think you would like it. It's really beer. You know, it has a nice color, it has lots of foam, but it's bitter. Or maybe you also like bitter, right? So for those who like bitterness, this is the ideal prophylactic. And we have no idea what the molecule is so far, because after many years of work, we published in this International Journal of Parasitology with Andrade Neto, who is also used to be a PhD student at my lab. He had to find sporozoids and test against the sporozoids. And then we find this amazing result. In the figures there are with monoclonal staining, and this is a liver stage. So we infected the cells with sporozoids. But before infecting the cells with the sporozoids, we treated them either with the Indian beer, which is the B, or with primaquine. We know that primaquine is a synthetic drug that acts against the liver stages. And as you can see in D, there are no parasites at all because primaquine killed all of them. We don't know exactly how primaquine works, but we know that it works very well against the liver stages at the beginning of the infection or even against the late stages of the infection that induce the relapses that I already mentioned in P.vivax. So my plant was not as active, and this is a ethanolic extract. It's not the crude extract. It's a bit purified. So you see that the parasites are dead. You have fragments. We have measured. The controls are in A and C. So you have those round, beautiful parasites. So my student was so patient to count them in several slides and measure the size. And in the Indian beer, we had nothing. I don't have the figure, but you can find it in this International Journal of Parasitology. We gave it to mice, and the mice were protected. Some mice were cured. So we treated the animals as people do before they enter the area. We gave them a solution of the Indian beer crude extract. We treated them for 3 days, and then we challenged them with sporozoites, and then we followed parasitemia. In 5 days, parasitemia is already there, and some of them were cured. About 50% were cured. So indeed, that's why I think this is the most important plant that we find. And why I cannot find the molecule? Because in Brazil, we don't have mosquitoes that you can infect with the Bergii. I would need either to test it in people, and I don't think that I would be allowed to do this, to have mosquito biting people and treating them before, or using monkeys. So monkeys are very expensive model, and I don't think I could rely on extract. So I think this is an open thing. I was reluctant to publish it before the molecule, and the journals gave me a hard time. Nobody wanted to publish it without the molecule, but then I think they were convinced that the issue was important enough to do so. So now I come to the synthetic drugs. This comes from the plant that is in the Cerrado also, the IP, tabebuia, which is a source of lapashol. So those phenazines are lapashol derived. We tested several phenazines. I think so far we have tested about 25 molecules of either lapashol derived or phenazine derived. One of the paper is just being published by Bellotti in the Memorias this year. And there we describe other molecules which are active. In this particular paper in Bioorganic and Medicinal Chemistry Letters, they were active in vivo only if the mice were treated by subcutaneous route, not by oral route. And so the mechanism seems to be a little bit different from the drugs in general that are given by mouth. Another approach that we are using that has been very promising is to test hybrid molecules. In this case, it's a collaboration with an industry that belongs to Cruz, which is called Farmanguinhos, and they have put together artesunate, that you see there, the molecule in the left, and mefloquine together, and in the presence of carbonate, they have made a salt. And this is a hybrid molecule that we have tested, and it was a very active molecule, more active than the mixture of the two drugs combined. You know that we use in endemic areas a combination of drugs. This is recommended by WHO. You no longer treat malaria with one thing. So the most important combination is artesunate or other artemisinin derivatives with a quinoline molecule, which in this case is mefloquine. So in Brazil, the Minister of Health it provides the sources for diagnosis and treatment. So people don't pay for it, and I think that's why we are successful in controlling the malaria transmission. And they are using this mixture, which is very expensive. And now the hybrid, I think it's going to be a solution, and we are planning to do clinical trials with this. The third approach is the molecular modeling, and this is the second author is William Cortopassi, who is present here, and the first one is a PhD student as well as others there, and then Professor Thanos and myself were responsible for this. They did the molecular modeling, and they found, in this case, using the lactate dehydrogenase enzyme, they found good targets. And you see the value of the energy of binding, and what we did, we tested them And we were happy to find them commercially available. So it's clearly shown that those three molecules, atorvastatin, itraconazole, and posaconazole, which are used against other things or to low down the cholesterol, they are quite active in vitro. Not as much as chloroquine, but when we tested in vivo, we were very happy to see that they were almost as good as chloroquine is. So now we can recommend that if you are in an area where you cannot find anything, we can just use artesunate with one of those statins to treat your malaria. And this is another enzyme, and I'm not going to go through because it's already published, topoisomerase, in which William is the first author. And then we use the same approach to test the mechanism of action of two new chloroquine derivatives. So our collaborators are synthesizing new chloroquine derivatives, and they were very active, and it's clearly shown that the way that they work is like the chloroquine does. It inhibits the polymerization of hemozoin, and by doing so, the parasite is killed. So we think this is a second molecule, synthetic molecule. This is very easy to synthesize and to produce in large amounts and to test. Now, the last project that I'm going to talk about is looking for derivatives of drugs that could replace Primaquine. As I told you, in Brazil, our big problem is not falciparum. People don't die of malaria, usually because we have very low amount of falciparum transmission, but they have Vivax. And Vivax, it will give you relapses, and the morbidity is very high. Even though you don't die, you can stay a week out of your work, of your job, and though Primaquine is used to prevent relapses. So every patient that comes with Vivax takes chloroquine and Primaquine. Okay? So Primaquine is the only antimalarial available to eradicate Vivax. It acts against the late hypnozoic stages, which we don't have. And only 2 groups in the world have these forms. So, but it also is used to block malaria transmission because it acts in the mosquito cycle. So we are working around this line, finding drugs that block the transmission. And I'm showing you some new molecules that act against this stage, the sporozoites or the oocyst stage. And we tested so far those derivatives, Primaquine derivatives. This is published. So we are now showing that they are not hemolytic. This is the hemolysis caused by Primaquine. As you see, even in small doses, 125 micrograms per ml, Primaquine lyses the red blood cells which are G6PD deficient. And this is the problem of Primaquine. If you have people that are deficient in this enzyme, it cannot take Primaquine. So our molecules, you see in the last line, the Primaquine thiazolidinone derivatives cause no hemolysis, even at very high doses tested. And the oral toxicity is also absent. As you see in the top line, all of them, the mice treated, they are alive, and those treated with Primaquine, they died 24 hours after treatment with a very high dose of Primaquine. The conclusion that those drugs are not toxic in vitro or in vivo made us look for this challenge to test against the mosquito stages, which we're trying to publish this result, and I think it will come finally. It was accepted. We used a very nice model that we developed with avian malaria and Aedes mosquitoes, which can produce the oocysts and then the sporozoites, which are shown in the middle figure, the salivary glands, so it's the very tiny thing. Those are the infectious forms, and this is the host that we have in Brazil. We cannot grow it in the lab, so we have to rely on models, and this model worked very nice. We infect the chickens, we bite them with the mosquitoes, and then we count the oocyst formation. The oocysts, as you saw here, it's very easy to see in the light microscopy or stained. And the results are Primaquine inhibits completely the cycle, and so do some of the primaquine derivatives that we are working with. So even if they are not as active as primaquine, they are 100 times less toxic. So we are very optimistic about using them to block malaria. And here you see one of the hybrid molecules, which is Primas. Primas is a hybrid between artemisinin, which is active against the blood stages, and primaquine, which is active against the liver stages. And you see that in the first Primas, you see that it blocks it inhibits the infection of the mosquitoes. Not totally as primaquine does, but as I told you, because it's less hemolytic, it's much better than primaquine. So we are working this line. In the figure there, you see how we measure. This is a midgut. It's the stomach of the mosquito that was fed. So you count those little round things which are easy to see and easy to count, okay? And those are the results showing that they work in gallination, blocking, not totally the mosquito, but they block. But if you look at the mice, and for this I had to send a student to the US, to the Johns Hopkins Medical School, and she worked with Fidel Zavala and others, and she was able to show that in the mice, all those molecules inhibit 100% of the oocyst formation. And this is very good news. As I told you, we don't have the Bergia in my lab, but we can send the students and use the collaboration abroad. And she also saw in delivery stages, and she was able to find that one of the molecules, which is the 4M, reduced 92% the liver infection, which is also very good news. Now, we don't know if it inhibits the epinozoids, but there is a direct correlation between primaquine and epinozoids, so we think that this also inhibits epinozoids. They were also active against the sporozoites in vivo. So she treated the mice with the drug, the 4M, and then she challenged them with the sporozoites given by intravenous route to the mouse, and then she followed parasitemia. In the black, you see the non-treated mice, and in the yellow, in the right-hand corner, you see that the drug 4M significantly abolished the infection by increasing the pre-patent period, by curing some of the mice, or reducing parasitemia. The conclusion is that we have very good molecules which are not toxic, not hemolytic, and that are active against the mosquito stages, the blood stages, and the liver stages. So we think that we reached one of the goals that I promised you at the beginning, to find one drug which is very active. There is a group there that we collaborate with, working with a prodrug, but it was not as active as the other one, but at least the paper is published recently, so you can have an access to it with the details of the methodology that we are using. As far as the resistance of the parasites, this was totally different. We are not dealing now with chemotherapy. We have to find out if we can settle a model in ex vivo in the endemic areas. So my student, Ana Carolina Aguiar, who also was in the United States and now is back to Brazil, she is now at this moment at the endemic area collecting blood from people. And then she found in this first publication that the parasites had mutations in one of the resistance markers, but our Vivax parasites did not. And most important, she was able to cultivate in a short cultures the Vivax, which is for, I don't know if any of you as biologists or a medical doctor, it's impossible to cultivate blood stages of Vivax so far, but you can cultivate them for a few hours, like 72 hours, and then you can do the test. So now she is showing that she can measure the resistance, and she has found only one strain that we had a patient from Africa, you see, in the third column. This is the IC50 of the drugs, chloroquine, artemisinin, and mefloquine. So this strain is totally sensitive, whereas the strains that we have from falciparum, they are, I would say, most of them are resistant to chloroquine as expected. Those are the collaborators that we have only in the last 8 years. I'm not mentioning the previous collaborators because then I will take another minute to do so. But I can tell you they're all chemists. Only one of them is a medical doctor, which is in the north area, and he is the one that has the permission, even though I am a medical doctor, I'm not there, so he's there. He has the access to the patients, and we have all this, the ethical committee has approved our work, and that's where we hope to to do the clinical trials and to test for resistance. All the others are chemists. As you see, they are outside the endemic area, but now the government has been very worried to establish good groups in the endemic area. So now we have in Rondônia, which is very close to Bolivia, in the left corner of Brazil. RO is for Rondônia, that's where we work. I haven't updated this paper, but you see from the green map that where the endemic area is. So we are now working close collaboration with the endemic area people for the malaria, the human malaria issue. And those are the students and the collaborators. In this big here, we had a little party during a meeting that I made to have all of them coming to Belo Horizonte so we could discuss the protocols at the beginning of the project, which was in 2010. We have been supported by CNPq, which is a very important, I think it's the most important funding agency in Brazil. And CNPq is the one who is paying for the fellowships to send the students abroad. And next we are going to try to start a collaboration here in Oxford with people that are interested in malaria. Carolina is a very important person in this project, and she is finishing her PhD now, and she already will be a postdoc. And Dr. Thanos, who is there, is in charge of the molecular modeling, and William, who is here, we are also keen to receive people from Africa to train them. So this is one of the people that came with a very important fellowship to us. Fellowship, it used to be called Third World Academy of Science. So he spent 1 year with us, and now he's back. He's a biochemist as well, and he's working in Nigeria. Thank you very much.